So y'all don't know me yet. I completed my fellowship about a year ago. And so I'm doing research now with Kingman. So thanks to Kingman, he is the mentor. He deserves all those mentorship awards because this talk was actually inspired by him. When about 6 months into fellowship, I was like at the VA going like, what's up with this? I like took the screenshot with my phone and I was like, why does it look like this? And Kingman's like, why don't you do a grand rounds on that? And so here we are. So this is this patient at the VA. So he's 36-year-old vet with some severe psychiatric comorbidities. He had oral stigmata of sleep apnea, so like the scalloped tongue, crowded teeth. But his home sleep study just had this respiratory event index of 0.9. And so here we start with a quiz for the fellows. Anyone want to chime in and say what's going on here? All right, someone jump in, dudes.
Hyperventilating or like deep breath, sorry.
So this guy has severe psych comorbidities and looks like he has a crowded airway and all of that. And his REI is 0.9, which is surrogate of AHI, not significant, but looks like he has mild sleep apnea.
So just look at the signals. Like, what are you seeing? So we have N1 here, and we have REM here.
Okay.
We have the EOG up here. We've got the EEG up here. And then here are the respiratory signals. So nasal flow is here. Thermistor is here. Chest and abdomen rip bands are here, down here. And so, and this is what happens. So this is in N1 and this is in REM. And then we have, and then here are the leg leads here.
It looks like in REM there's some, I'm not sure what this is on the flow signal. There's these kind of double notched on kind of these two notches on the inspiratory side. And then it looks like some paradoxical motion, the chest and abdomen. Looks like abdomen's going out, chest is going in at the same time.
All right, so there, focus on that. So we've got the thermistor. One thing to see, the thermistor looks fine. Like if you didn't have your nasal flow signal, you'd be like, there's nothing going on, but he's paradoxing. So yes, there's a lot of paradoxing. There's these irregularities in the nasal pressure signal. And then what also is occurring, you got all of this junk in the, he's got, this is REM. So this is like REM without atonia based on all the little random movements. And then there's also a lot of high frequency intrusion in the EEG. And this guy had this going on all throughout his sleep study. It's like this guy couldn't really get into any decent sleep with this. And you see this a lot in people with depression, this alpha intrusion into their sleep. And sort of, I see, just when I read sleep studies, I see this a lot in these people with this mild sleep apnea, UARS type situation. They have a lot of this high frequency intrusion with the psych comorbidities. All right, so objectives of the talk: understand the basics of the flow measurements, understand Starling resistor. We're going to go on to all of this stuff as a Starling resistor is a conceptual model. Then we're going to talk about nasal flow limitation and negative pressure dependence, and then appreciate what's going on anatomically in the airway. I've noticed.
Denise, can I can you go back to the first
Sure.
example for a second?
Sure.
Just in terms of when for the new fellows, when we say describe this epic or describe this thing, what we really want you to do is, even though you might have this 36-year-old and all this sort of stuff, we want you to go through and break down the signals. And the reason for that is that that's what you're going to do a year from now. That's what a sleep specialist does, is they know every signal on there, and they can almost explain everything that's going on in this 18 channel. It's a daunting task. That's why it takes so long. But so when Denise or somebody says, do this, and I know that Zach sort of went right into where the flow signals were, but you know, you can always start off by saying, well, this is the EOG, and this is the chin, and this is that. And you can collect your thoughts when you do that, and then sort of see what's going on. Because I think that the paradox, for instance, in REM sleep is pretty subtle because the abdominal signal is pretty subtle. So I just wanted to point that out to people. Okay, I'm sorry.
All right, no problem. All right, no disclosure. So let me just talk about the flow channels first. So this is, by the way, this Barry book, Fundamentals of Sleep Medicine, it's on Clinical Key. You get it for free through Clinical Key. You log on through UH, and you just need to read this book. This is the book. You go through this book during fellowship, you're going to do fine on the boards, and you'll know stuff. So it's a very easy read. Anyway, so pneumotach is the gold standard. And then I'm going to talk a little bit the nasal or thermistor, the nasal pressure, PVDF, and CPAP flow. So that's what the machine measures. It's basically this pneumotach. So what is a pneumotach? Pneumotach is simply you're measuring, it's like a screen or an array of little capillary tubes that create a little bit of resistance, known resistance across, and you measure the pressure from one side to the other. And so your flow is going to be your change in pressure divided by the resistance. So it's a linear relationship. And that's what a pneumotach is. And so when you do, this is used in research, it's basically a CPAP mask attached to this thing, and you're just measuring the pressure across this known resistor. So that's all that is. Okay, thermistor. So your thermistor is a little temperature measurer.
Wait a second. Everybody get that? Everybody get that? Because none of these people are plumbers, right?
You guys all got it?
Sir. Yes, ma'am.
So basically, so I can understand. So it has a set, I'm just trying to look at the math here. Mm-hmm. So it's measuring, so it has a set resistance or a known resistance.
It has a known resistance.
Gotcha. Okay. So basically it's deriving the flow from the change in the pressures.
Exactly.
Okay. All right.
So, yeah, the change in pressure across a device in which the resistance is known. It doesn't have to be linear. It can be all sorts of crazy things.
Sure.
But it's this pressure difference, and then it says, okay, this is what changed going through this tube. And this tube could be anything. It could be a nose on one side and lungs on the other. It could be, that's the upper airway. It could be anything. Okay. But this is called a pneumotach, and you generally put it onto a mask that then is put onto the patient's face, and then they breathe in and out of this pneumotach and gives you flow signal.
Right.
And the surrogate for that is pressure.
Mm-hmm.
Makes sense.
Okay.
All right. So now your thermistor, so that is just a thermocouple. And so it has like a little thermocouple here at the nose and another thermocouple here. So the nasal oral thermistor. So it's measuring warm air coming through the nose or the mouth. And the thing to know about this, it's not proportional the two flow. So the changes in temperature. So if this is like this flow here, so here's your flow, and so here's pneumotach flow here. And so if you had a linear relationship, it would be like this. But in a thermal flow, it overestimates at low flows and underestimates at high flows. So it's not proportional. So this makes it really good for apnea detection. So when there's no air flowing at all, there's no temperature change, and so you don't see a signal, but it's not good at detecting hypopneas because it underestimates. Okay, do you guys get that?
Yes.
Yes? No? Do you get it? So there won't be much of a change if you go from, so if you're at 100% breathing and you go to 70% breathing, the thermistor isn't going to show much of a change.
Mhm.
Okay, but if you're at 30% breathing and you go to 0, it's going to show it really easily. If you, okay, you guys get it?
Yep.
And then the other thing to know, it's a slow response. You think about, you know, temperature changes are slow versus pressure changes, which are fast. So there's going to be a lag in this signal compared with the pressure. All right. Do you guys all get that?
Yes.
All right. All right. So the nasal pressure signal, like Kingman alluded to, is basically your pneumatac type device, but instead of having a real known resistance, we're just using the nasal inlet here. So we're measuring the pressure inside the nose and outside the nose. And the resistance device is the nasal inlet. And so this is really good at showing changes in airflow. So, but so here is your pneumatac showing, okay, let me explain this. So the thing with the nasal pressure is that it will drop down quickly as you get to a low flow. So it looks like there's less flow than there actually is here. So this is the pneumatac, here's your nasal prongs. And you see that it's like overestimating the decrease in flow. Do you see that, guys?
Sure. So trying to understand this,
All right.
pneumatograph is the pressure one.
Yeah, this is the gold standard on top.
Okay.
And then this is the nasal prongs. So this is, and then they have this linearized nasal prongs, and no one does this, but it's just for semantics, the flow is actually the square root of it, but no one does that in practice. We just use the plain nasal prong pressure. But so a decrease in flow is going to show up more than what it actually is. Do you see
So
that?
flow shows much more significant compared to pressure signal.
But compared to the gold standard pneumatac. So here is someone who's breathing, he starts a hypopnea and then resumes normal breathing. And in the nasal prongs, here's the normal, and you see the signal goes down more than it would in the gold standard.
Okay.
So it overestimates this. And then conversely, when this person started rescue breathing, it's more of a signal up here. So this is good for detecting hypopneas, so small decreases in breathing. But you can't use it as well as an apnea because its pressure, its signal is going to go down too much. So this isn't really an apnea, but you might be like, oh, this is close to an apnea, but it's not.
Okay.
Well, it's good enough. It's
All right.
It's close enough because it's at least a 70% flow.
Right. But it just overestimates. So you'll see signals where it looks like an apnea on the nasal pressure signal, but then you'll still see a good thermistor signal. And so you use a thermistor signal to see if it's actually an apnea. Does that make sense to you guys?
Yeah.
All right.
Well,
All right.
the principle is that nasal pressure is different from the thermistor. And you just really have to know that when you're looking at those two. And if you remember the first example, they look different. Okay.
All right. And then in the kids, we often use these PVDF sensors, which just get taped under here. And it's a combined thermal and flow signal. And it uses electrical signals generated by this film. But it's a fairly accurate estimate. So when you compare the PVDF signal to the pneumatac sensor, it's very close to like linear, very, very similar to it, but they're more expensive. So we all use the nasal cannulas. All right, so I'm going to admit that 6 months into fellowship, I was still pretty confused about these squiggles. And so where are you guys now? Is this confusing to you? If you get something like this, are you like going, what is this? Are these
no,
oriented
but
right?
I find myself thinking every single time, is this flow limitation? And I ask myself that maybe 75 times per study. So
All right.
that's where I'm at.
So let's start. Are these signals oriented correctly?
No, the chest and abdomen is going in opposite directions.
Right.
Yeah, like Zach said, there's a flow limitation. Not at the initial inspiration, but at the peak of inspiration.
So is this oriented properly? Okay, so it's really easy to figure out the chest and ab, like, is this paradoxing or is this flipped over? You just have to, like, you know, obviously this is flipped over, but you can always go back to the calibrations and look at your signal. So it's really important at the beginning when you read a sleep study, go to calibrations, make sure your signals are oriented correctly. And so chest and abdomen are easy, but then how about your nasal pressure signal? So now we have the next little quiz here. Which one is in the correct orientation, inhalation up, and why? Here we go. Oh, it's not playing. All right. So I had my Jeopardy thing that didn't work. All right. So anyone, so the A or B is in the correct orientation.
Isn't it A?
Why?
And because the upward deflection is the active motion, and then the downward is the passive breathing, and then hence it's not as strong. Well, it's not as powerful as, say, the pressure-wise.
Does anyone else have?
There's something happening here. It's not like a nice curve in either graphs.
So this is a normal signal. And I would want you to know this is a normal signal, and one of them is upside down and one of them is right side up.
Yeah, I think actually the normal one is B.
Yeah.
Yeah,
All right, and why?
Well, it's the initiation of the breath. I guess it doesn't deflect that sharply at the beginning. I'm not sure how I can explain that.
All right, so this, you guys are gonna love this. This was, oops, now it did it. Okay, so this is, you're never gonna forget this now. You're gonna be like, oh, thank you. So inhalation, so the correct answer is B. So inhalation requires effort. So you start out slow, you get up to a peak, and then the pressure, the negative pressure that you're using to inhale goes up and then goes down, okay? So you get a sinusoidal signal. You see this? Your sinusoidal signal. But exhalation occurs by your passive recoil. You go, psh, so it's like a sudden deflection with a gradual return to baseline. So here's your sudden deflection. And now is a gradual return. So you're looking for this little slope. So do you guys see this sinusoidal shape? And then like that. Does that make sense to you guys?
Yes.
Yes.
All right. All right.
I don't think they've ever seen an esophageal pressure wave before.
Oh yeah. So this is the easy way to know whether you have inhalation and exhalation. And so this is like in a research setting. Stanford used to do this, but they stopped doing this. But the esophageal pressure, you put your little pressure transducer down the throat. And so it's monitoring the pressure transmitted into the thorax. And so it becomes more negative when you inhale, and then it goes positive when you exhale. And so this way you can very clearly determine, okay, this is inhalation, and then this is exhalation. Inhalation, exhalation. Guys get that?
Yes.
All right. This is the thing with Zoom. You can't look at people's faces and look for puzzled faces.
So the other thing to note is to see the peak flow. Where's the peak esophageal pressure? At the end of inspiration. And it's different because you have your elastic recoil of the lungs and chest wall. But you breathe up and up, and then whew, then go all the way down. All right.
All right.
So if you were in 1981, fellows would be putting on esophageal probes, making the balloons and putting them down into people to be able to detect obstructive apneas from central apneas. All right.
All right. Now, and then another thing to look at when you're looking at the flow signal, the nasal pressure signal, is that you can have a pause after exhalation. So when you normally breathe, if you slow down your breathing, you don't pause during your inhalation, you don't hold your breath, you pause during exhalation. So this pause is normal. And so then you want to make sure that you don't confuse this with like an oral exhalation that's not picked up by your nasal pressure, or some sort of oral leak, stacked breath, which is something that you would see in this. So this was a nasal CPAP flow. So normal, 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 and then suddenly you're getting this line here. So this is not this little exhalation line. This is the signals dropped off. So it's not going to whatever it's detected. So the CPAP, this is like the person is blocking their nose. They're either exhaling through their mouth, or they're actually, their soft palate's gone up and it's blocking an exhalation through into the CPAP mask. And they may just be stacking their breath. But that's what you're seeing here. So you want to be able to understand that an exhalation, normal exhalation, has this shape. It does not have this shape. There's something wrong here. Okay. So have you all seen this? Have you noticed this when you've looked at studies?
I have not seen that, but
I haven't seen
maybe I
that.
just didn't notice it.
You didn't see it. It's there all the time. So you could keep an eye out for that. All right. So now more onto this. Here we go. All right. So what's going on here? So this is from a paper, and they're pulling a little ringer on here because now they have a nasal thermistor flow and a nasal pressure flow. Okay. So let's see. Now we have this. There we go. All right. All right, guys. Anyone want to dive in?
So looks like the thermistor's on top and the pressure flows underneath. And it looks like at the beginning, you're having some kind of tachypnic or hyperpnic breaths, and then the pressure signal sort of drops off and the thermistor continues. And then you have the increase in your thoracic and abdominal deflections, followed by an arousal, and then kind of a resumption of, looks like maybe one breath. And then it kind of cycles through that same process again with the drop off of the nasal pressure flow, increasing effort, an arousal, and then resumption of the pressure flow.
So how many hypopneas do you think?
Two separate.
Now the funny thing with this is that if you look at the definition of hypopnea, you have like two normal breaths, but we haven't, according to this, right? So there's definitely something going on. I agree. So this is just going to show you what's going. So these guys had an oral pressure monitor. They had an oral flow. They had a little transduced pressure thing like around the mouth to do what it's doing in the nose. And so they were picking up the flow with that, the oral flow.
Oh.
And so, this thing didn't. So so what you're seeing, here's this hypopnea right here. And my slide, I screwed up my slide, but here's the hypopnea right here. And so then there's rescue oral breathing right here. That looks, you can't detect it because they're mouth breathing. So your nasal pressure signal doesn't pick up a signal if you're mouth breathing. And so here's your other hypopnea. So these is right here, and then there's rescue breathing or oral breathing after that during this arousal. So basically, he was doing some nasal breathing. So here you have your nasal pressure flow. Then he had a hypopnea, and then he had an arousal where he started breathing in his mouth, with his mouth, and then he did again. And each time there was a desaturation. But so you can imagine, so this looks like it was a 3% desat. So if someone desatted by just 2% and doesn't even pick up as a desaturation, you'd be like, how do you even score this? Right? So these would end up being just raras if you decided that this was a respiratory event. But so the point of this is that in sleep apnea, there's a lot of mouth breathing going on. And so this can impair your detection of airway events with the nasal the nasal pressure signal. And if you look, the thermistor didn't show much, showed a little bit. They didn't give us enough of the normal baseline to do this. But just, this is a good illustration of how much the nasal pressure signal will miss if there's mouth breathing. And in normal people without sleep disordered breathing will breathe through their nose 96% of the time during sleep, compared with sleep apnea, which is like 40 to 85%. All right. Now we're going to move on to flow limitation. So flow limitation is simply an absence of an increased flow despite increasing effort. And so the definition of inspiratory flow limitation, according to the American Thoracic Society workshop on inspiratory flow limitation, is flattening or scooping for greater than or equal to 75% of the inspiratory cycle. And then you can also get expiratory flow limitation, which means that your maximal expiratory flow occurs with tidal breathing, which is like this crazy definition that took me a long time to get my head around. But basically, if you put a vacuum, so if you put your CPAP mask on, you try to vacuum out air, more air doesn't come out. So you can't increase the flow with the vacuum, basically. All right. So here is this figure from this classic paper on flow limit, using the nasal cannula to detect flow limitation. And so here is this glottic pressure. So that's your esophageal pressure, basically, but it's just a catheter that they stuck down and it's hanging around by the glottis. And then here is your cannula flow. And so right here where you have a normal contour, if you graph out your flow versus the pressure, so the more driving pressure you have, the more flow you have. So that's normal. That's no flow limitation. And then you can have a situation of intermediate flow limitation right here, which actually looks pretty normal because you kind of have a sinusoidal shape, but it's not. And so at this point, here we have the pressure, driving pressure here, but the flow is starting to decrease with increased driving pressure. So instead of going all the way up, it's bottoming out. And now when you have this very flattened contour, this is very severe flow limitation. You're not getting anywhere. You have a low flow despite high pressure that's trying to drive it. Okay, so
go back again.
Sure.
This is really important because you see this all the time. And so what you don't see is the glottic pressure, right? You don't have that on your thing. So glottic pressure is like esophageal pressure. And if anything, this pressure has to be below the level of the obstruction. So on the left, there's no flow limitation. And if it was absent or really low, you'd have no flow and a driving pressure would go across the x-axis. So when you're seeing these shapes, you have to think of what's going on the glottic pressure. So if you take a deep breath and you relax your nose, you'll have flow limitation. If you expand your nose, you open it up, and every effort you do, you have an increase in flow. So this is the upper airway. This is the upper airway. These are all the questions that Denise is asking, I'm asking, people have been asking for a long time, is how does it do this? And what does it do? And what's the reason? And how do you treat? Okay.
Right. Oh, so this other thing to note is that normal airways don't require as much negative pressure to.
They hardly require anything.
Right. But people with sleep apnea can generate ridiculous negative pressures to try to inhale.
Ridiculous being?
Being like greater than -50, -80.
Right.
Bad.
Right.
Whereas normal is like, -5, -10.
Well, 2, 3.
Okay. Even less.
Yeah. Supraglottic is 2 or 3.
Yeah. So.
I'm sorry to interrupt, but I mean, this is really key. This is really basic stuff. And I'm realizing that this is a lot for people to unpack that's never thought of mechanics before. Right? Because if anyone has ever done cardiac circulation or blood flow through tubes in your vessels or your coronary arteries, they go, oh yeah, I know what you're talking about. But if you've never really done that before, there's no other field in medicine other than pulmonary critical care or in cardiology that thinks about these issues or presents them clinically on the wards, right? Sorry.
No, please, it's good. All right, so flow limitation. Precedence of inspiratory flow limitation in asymptomatic people with an AHI less than 5. So we're trying, asymptomatic means we're not getting the people with upper airway resistance syndrome. So that means, so they had about 9% of breaths showed inspiratory flow limitation, and the upper 95th percentile was 31%. So basically, if you're seeing more than 30% of your breaths with inspiratory flow limitation, there's something going on. So even if your AHI is less than 5, person is symptomatic, and they have a lot of, more than 1/3 of their sleep study has flow limitation, you're looking at a UARS picture, so upper airway resistance syndrome. So this is someone who's not being captured by our definition of sleep apnea, but has significant, it's maybe symptomatic from sleep disordered breathing. So this is someone that I would try treating their sleep disordered breathing before saying, oh, you've got like idiopathic hypersomnia, or you've got insomnia because of all sorts of other things. Okay, and so moving on, so positionality makes the flow limitation worse. So supine is worse, just like in sleep apnea. So just think of gravities, falling bits into the airway. And then the other thing to think of, that's going to blow you guys' mind, but lung volume changes with position. So your lung volume is actually lower when you're on your back than when you're on your side. And so with a larger lung volume, you end up having tension on your pharynx. So your pharynx is attached to your base of your skull and your jaw. Okay, there's no connection anywhere else. So the lung is creating tension on your pharynx. Do you guys get that?
Mm-hmm. Yes.
Okay, so the larger your lungs are, the more your pharynx is stretched. And so the stretching of your pharynx is going to decrease all this like ability to fold inward. And so that's one of the mechanisms of CPAP, is just increase your lung volume. It's not necessarily a stent in the airway. You're making your lungs bigger with that extra pressure. All right. And now consequences of flow limitation, arousals, perturbation of sleep. So PLMs can occur as a result of inspiratory and expiratory flow limitation. So you can have that leg movement, like in that sleep study I showed you, this so-called, you know, REM without atonia was because of his flow limitation. And so this is not included in AASM scoring at this time. All right, so how do we conceptualize this? And now we're gonna talk, this is Kingman stuff, Starling resistor. So we can conceptualize the airway as a collapsible tube on either end of rigid tubes. So here, so this is, you got your collapsible tube inside a sealed box, and you've got pressure inside, which is your fluid flow, oops. And then you've got the pressure in the sealed box, which is going to determine whether your airway is open or not. So flow will only occur when this pressure is greater than this pressure. And so this pressure is basically your P crit. Okay, oops, sorry.
Sorry, can you go back, Denise?
Sure.
Can you explain that one more time?
Let me show you in this, because I'm gonna go on here. So here's your collapsible tube. If the pressure in here is less than this pressure, so if the pressure here is 5, the pressure here is 10. The pressure in the box here is gonna collapse this tube, and there's gonna be no flow. Do you see that?
Yes.
And then, but if the pressure in the tube is greater than the pressure in the box the whole time, you're gonna, your airway is gonna be open. You see that? So it's 15, there's resistance going down here, but at the end of your airway, the pressure is still above the pressure in the box, your P crit. It's gonna stay open, you're gonna have free flow. And the pressure, the flow is going to be proportional to the upstream and minus the downstream pressure. Okay, but in the flow limited state now, which is what we're talking about with sleep apnea, is the pressure. So the pressure is in the airway is lower than the pressure needed to keep the airway open. All right, and so this downstream pressure is less than P crit. And so flow is gonna cease until it's able to keep this open. There's gonna be fluttering here. And so you'll get stable flow only when the downstream end of the resistor is at P crit. And so the flow is going to be proportional to the difference between the upstream pressure and P crit. And so it's no longer dependent on the downstream pressure. And then the resistance is the resistance along, oops, along here.
So just so I understand, so there's this change in the pressure, and is this inherent to this Starling resistor, that as you go down your resistor, you lose flow or you lose pressure? I'm just trying to understand what because you had this P outside pressure, this plus 10 in your box. So why is the P in different on the downstream end versus the upstream end?
It travels along a tube.
Okay, that's what I'm trying to understand.
Right? Okay, let's go back to those 3 again.
Like this?
Denise, yeah, okay. So on the left, it's going to be upstream. On the down is downstream. And the reason, and in sleep, thinking of sleep apnea, the one on the left is going to be your nose, and the one on the right is going to be your trachea. Okay. So in the middle is the sealed box. You usually don't think of your airway is a tube of air that goes through the bony structures and the soft tissue and the mucosa and all that sort of stuff inside, right? And inside air, then that size of that tube is dependent on all the stuff that's there. If I put a 10-pound sack of flour on your neck, it's going to close that airway, right?
Right.
So the question is really, it's always been, you know, how do you get to know the properties of this tube this way? So if you go to the next slide, what you'll see is that in this particular instance, they have an upstream pressure of +5. Now, it's not a really good example, but never mind. But the outside of the tube is like having a, you know, some sort of weight on your neck. And so the pushing pressure of +5 can't get through that tube because the outside of the tube has a higher pressure.
Okay. And so, and then on the next slide.
On the next one here, then you increase that from +5 to +15. Now go back one, +5 to +15, and it's bigger than the +10, but it has to travel along a tube and it has to wiggle around whatever it is. In the upper airway, it has to wiggle around the velopharynx, the oropharynx, and the epiglottis, and it wiggles down into your trachea. And still you can breathe in because the driving pressure is, or you can push air in because the driving pressure is high, but it's not as high as it was when you first started out because of the resistance of that airway. Now on the next one, on the next example.
Right, so I'm gonna just, so if you look at this one, so the pressure goes down by 4 as it goes along this airway. So now if you have a more resistive airway here, now the pressure goes down by 6.
Right.
And now you're below P crit.
Okay. So you're going to inherently lose some flow based on the resistance of your airway, and depending on the factors, the pressure and the resistance, you may have a certain threshold at which there's some collapse kind of on the downstream end.
Yeah, you're going to lose pressure as you go down.
Okay.
Now, I don't know if Gold and Schwartz would say that CPAP adds to P downstream, because really its flow is related to the upstream pressure. So that's okay.
Okay.
Just in terms of your slide.
Okay. So the way I think of it though, so to create this, if you're able to add pressure to here.
Yeah, but all that means is that, so the problem is with this Starling resistor is that this assumes you're pushing air from the left to the right. When really what you're doing in breathing is you're trying to suck air in from the left to the right. So and they always do that because then, you know, your next slide makes sense.
All right.
All right.
Is everyone clear on this?
So what you can do is if you increase upstream pressure, you will be able, and look at what flow is, you can kind of get an estimate of what resistance might be in that box.
Well, this would be representative of positive pressure ventilation, not necessarily the negative pressure ventilation that we have when we breathe.
Yeah, remember your physics. It doesn't, the sign change doesn't mean anything. Right?
It's all relative.
In fact, you were presented this in medical school as being the reason for expiratory flow limitation in the lung, and that was breathing out. And also you were presented it with how come there are collapsible segments in your blood vessels. But you know that your eyes glaze over because there's no disease that's related to it, except for in the lung, it's COPD, and it's the flow volume curve. Remember that in medical school? And then the other is coronary blood flow and regions that are depending on blood pressure and things of that sort. Okay.
All right.
So it says a Starling resistor is a variable resistor that depends on the outside, the properties of the tube. All right, here you go. Measure it.
So how do you measure P crit? It's Much simpler than you ever would imagine. All you do is drop your CPAP pressure. And so you plot your flow as you drop your CPAP pressure. And so here, so like if you get a pressure of 9, you're up here, pressure of 6, pressure of 3, and then you can just extrapolate down to no flow, and that's your peak crit.
Denise, can I ask for the other fellows, because the term I've noticed over the last year that the term peak crit is used a lot, and then eventually get to understand what it is, but they may not have a background on what the term actually means and what you mean when you say it. So it might be helpful to explain it to them.
Okay, so peak crit is the critical airway pressure at which point this guy's going to collapse, basically. This is the peak crit. So critical airway pressure. So if you're above peak crit, your airway stays open. If you're below peak crit, it closes. Does that make sense?
In this example, it takes a positive peak crit to keep it open.
So here, this is one of Kingman's slides. So here is.
Let's go back. Let's go back again.
Sure.
Let's go
Okay.
back. So any of the fellows that do not snore, your peak crit, show the peak crit. That do not snore, that whole curve is going to be shifted to the left. And in order to close your airway, I will have to suck on it, and it would be a negative peak crit. And then as I go from a -4 to a 0 to a +4, your flow will go up, and it'll go to a point where you get a maximal flow. If you're really bad with sleep apnea, your peak crit kind of goes to the right. That is to something like 4 or 5. And so one of the things we'll be doing on the next CPAP titration, Madhuri, is to create this curve. We'll know the flow from the nasal pressure, and we'll know the PN by the CPAP pressure. And we'll take about 10 points and we'll put those on a graph, and then we'll draw a line through it.
All right.
Right? At 0, there'll be no apnea. And at 10, at 0, there will be apneas, or whatever, 0 flow, there'll be apneas. And then at 10 centimeters of water, there will be none. And so you'll look at the flow and you can go all the way down. So that's what you're doing during a CPAP titration.
Sure.
All right, I'm sorry to interrupt, but this is key. This is basic.
This is important, right.
Basic. Okay.
So here is Kingman's slide here. So this is, so a normal person, you have to suck on the airway to collapse it. So here, if your peak crit is less than -5, they're never going to have sleep apnea. But if you're greater than -1, or whichever way, so your peak crit is high, you're going to always have sleep apnea. And then you have this area of vulnerable anatomy where you could go either way. So like between -1 and -5 for peak crit. Some may be hanging on, doing fine, and other people are having sleep apnea. And so why is that? It's because the Starling resistor is really an imperfect model. So this is like a simplified pharynx. So here's your trachea, your nose, and here's your collapsible airway. And if it were this simple, CPAP would be like a piece of cake, right? You just pressurize it, this expands and everyone sleeps fine. But that's not the way it works, because anatomy is more complicated. And this doesn't even explain expiratory flow limitation, which I mentioned exists. So, and the reason is you got all these flappy bits in the airway. So you've got your soft palate, you've got your epiglottis, you got your tongue. And then you also got these, so these are the high compliance things. And then they've got this low compliance stuff with the tongue and and the jaw that can fall into the airway as well.
Good job.
Oh, you like that? So, negative effort dependence. So this is where the harder you try to suck in, the less flow you get. So this is like even worse than inspiratory flow limitation. You're actually decreasing your flow. Okay, so this is like mild negative effort dependence, where it just decreased a little bit. Then you have serious, like then you've got like moderate, and then severe with greater than 50% negative effort dependence, where you can actually just close your airway the harder you try to breathe. And so this is common in sleep apnea. But there's substantial variability between subjects, and the negative effort dependence is fairly constant within a subject, according to this study here, but I think it really varies by sleep position as well, and maybe sleep stage. But so it's this negative effort dependence seems to be reflective of airway, being an airway property. And so there's two different flavors of negative effort dependence. So one where the airway will fully open. So here we go. So here is your esophageal pressure. Here is your flow. And if you look here, the breaths are returning to the baseline peak. You see that? The airway is fully open. And then you can have another type of negative effort dependence where the airway is not making it back up. The flow is not reaching baseline. So each breath, the airway is closing more and more and more and more. And this is going to eventually lead to a full-on closure of the airway. All right. So what about this thing? This terminal peak. What do you guys think is happening here?
That's the end of inspiration.
Right, but why do you think the flow is going up?
There's a sharp increase in the effort. I'm not sure.
No, if anything, the effort is less. See on top there, that effort is less at that point. So if effort closes the airway, there you go.
So the airway is relaxing, opening. So that negative pressure that you're generating when you're breathing is actually sucking parts of the airway in. And so that's leading. And so then when you release that negative pressure, it opens up because you're not sucking this bits in. Okay.
Yeah, I kind of see that.
So do you remember drinking through a cardboard straw and it gets really soggy and you're trying to have a milkshake? And the harder you suck, the less milkshake you get. But if you suck really gentle, you get more milkshake.
That's a perfect analogy. You're collapsing the straw.
And you realize that as a kid because you suck and you don't get anything, and then at the end of sucking hard, you stop, and all of a sudden the milk comes right, or the milkshake comes right up, and now that's where the milkshake is viscous. It doesn't happen as much when it's milk or when it's water.
Mm.
So you'll have to get an old paper straw. They'll come back. And why doesn't a plastic straw do it? Because it has more rigidity.
So you get a thin disposable plastic straw will work.
Right.
I'm going to have to try that with the silicone straws.
Right. Okay.
All right. So I don't know if we want to go on because we're at the hour mark.
What do you have left?
So I had some anatomy, and then I had like just a little bit of anatomy, and then I had I went over this Genta paper
Yeah.
that showed the difference in the flow in the nasal pressure signal shape based on what's collapsing.
Right. And how long does it take?
Well, I can spin through it quickly.
Well, I think the important thing is to go through it and say, so that they get an idea. We can go back over this because there's a lot to unpack here.
Yeah, there is.
But the major thing is that all these things that she just talked about are anatomically based, and there are things that we know, there are things that we don't know, and then there are things we don't know that we don't know. So this is how you could do research. People say, oh, can I do research? Yeah, all right. You got to have an endoscope in the back of the nose looking at the bulging palate and have it during sleep. Right? Now that's research. And what you're looking for is what happens. Yeah, show a little bit of this.
Okay, so let me just show the anatomy review so you know what you're looking at. Okay, so here's your tongue. The soft palate is back here. And then you have the epiglottis is down here, your hyoid bone. But the epiglottis folds over the glottis, which is in here, so your vocal cords. All right, so here, and so then when you're doing this nasendoscopy, you're sticking this endoscope down the floor of the nose to the back of the nose, and then you can look and you can see the soft palate, the posterior pharyngeal wall, and then the epiglottis is down here. So here's the tongue base, and the epiglottis is like right up against the tongue base. And so this is a study, they used natural sleep. So this wasn't a drug-induced sleep endoscopy, it was natural sleep, but it's a sort of a similar technology. And what they found is that the shape of the nasal pressure signal, this is using a tachometer. So this wasn't a nasal pressure signal, this is a tachometer. So the shape of the flow signal was reflective of what anatomic structure was prolapsing into the airway. And so the tongue showed this sort of low, a low negative effort dependence. So it just showed flattening, but there wasn't a lot of negative effort dependence. So just this plain flattening. And so here was this video here. Oop.
Upper signal is pressure, bottom is flow.
Yeah. Now what happened with this? No, it's not playing. All right, well, this means it'll be really fast. Interesting how it's not playing in, so it's not playing in Zoom. All right, so we'll just, too bad I took down those other slides, man. All right. All right, so anyway, oh, here it is. Okay. So here is the tongue base, and it's not doing much at all. And so you're just having this, oh, sorry. It's Mark Muller. So here's the esophageal pressure. This is laryngeal pressure, epiglottic pressure. And then here's the flow signal. And so you're just getting this flow limitation, this flat flow limitation right here. And when you see it, it's just this. Okay, and then when you have the palate falling into the airway, so here you're looking down, so here is this little the pressure transducer that's going down to the glottis, and then here's the soft palate. So when there's just isolated collapse of the airway at the soft palate, you have a little bit of negative effort dependence, most of mild to moderate. And so this is what it looks like. I don't know what's going on with this, but anyway, this, too bad you can't, it's not, the video isn't showing, but so.
You have to go down and turn that bar on.
Turn that bar on.
Remember, it takes some time for it to load up for your bar.
Oh, is that what it's doing?
Yeah, but that's okay.
Whatever. So this just collapses.
Right.
And so you'll show it, so the pressure's going down, and then you have a little bit of negative effort dependence.
That's snoring there.
There's snoring, right. Oh, there it goes. All right. So then you see it collapsing. So this is the soft palate collapsing into the airway. And this is what it looks like on your flow signal. All right. And then when your lateral walls collapse, there's moderate negative effort dependence. So in this case here, you're sucking. Here we go. This is a faster one. So you see the airway walls, they're sucking in.
You see that little dip at the end of inspiration
Yep.
too? The little thing that goes up there, Zach?
Mm-hmm.
Zach, you see that? And Maduri, you see that?
Yes.
Now you don't usually see that flow signal. That they usually that pressure signal they use in the nose just has had a time constant, so it looks smoother because people don't like it, but that's okay. All right.
All right. And so this has a high, these parts of the airway have high compliance, and that's when you see this good negative effort dependence, or this moderate. And now the epiglottis. So here's the epiglottis. So here we're showing, this is like really dark, but the tongue base is here. The posterior wall of the pharynx is here, and here's the epiglottis. And here the airway is right here is open, and here the epiglottis is falling shut over the airway. So it's getting sucked in. And so this is the epiglottic collapse on this in this flow signal. So you have some unobstructed breaths, and then suddenly, boom, the epiglottis collapses. And so here's just a review of the anatomy of the epiglottis. Here's your glottis. It's just this little cartilaginous flap, and then there's some muscles that insert into the soft tissues around it. And this is the view. This is the view if you're going to intubate someone, this is your view. And here's the epiglottis here. And so this is negative effort dependence. This is from Dr. Stephen Park, who's an ENT sleep doc in New York, who has a really good blog on sleep disordered breathing. But so this is what happens. And then the guy at the end of the video, they did a jaw thrust. But so watching it again, you can see this the negative pressure that you're generating with your diaphragm. So that's pulling that epiglottis right into the airway and closing it off. And so you can imagine, like some people with sleep apnea, you put a CPAP on, this epiglottis can act like a sail, and so some people will be like, I can't breathe with a CPAP. This may be what's happening.
Yeah, it's not a lot, but that's what you have to listen for when you hear that.
All right, and so this is what the epiglottis collapse looks like. And now that's an impressive. This guy's breathing through a straw. And so here you have these sort of bad negative effort dependence and these abrupt discontinuities. And so this.
Okay. All right, we need to move on.
Move on. All right. Well, good enough. Let me see if we'll leave that. Blah. Position helps with it. Closure.
So
Reduce the closure.
So yeah, we'll put those on to the drive at UH, and maybe take out your movie so it can actually be sent to people.
Okay.
Right. But or you can go and get Essentials of Sleep Medicine, because these guys at Johns Hopkins spent probably 40 hours to put their chapter together so people could understand it. So we'll see. All right, good.
All right.
What do you think, guys? What do you think?
I think it was great.
It was very interesting.
Well, this is
Fantastic talk, Denise.
This is sort of looking at particle physics in sleep medicine. It really is. Because it's going to be the fundamental feature of when I talk about mechanics, that's what I talk about. That's what I'm thinking in my head.
All right. I'm going to simplify it next year.
Well, I think we have to give it twice.
I think, yeah.
I think you give it once and say, this is what the airway is doing. And then here you've seen now 100 sleep studies, and you've looked at this. And now you're not going to find a lot of people interpreting studies in all three places, looking at studies while they think this way. So that's the problem. We're probably one of the few places that thinks this way. So Denise gave a Zoom lecture to Milwaukee, and you did this, right? The flow one?
No, I did the evolution.
Okay. Well, I'll tell you, if you give the flow one, they'll be blown away.
I have to give you guys the evolution one.
Yeah, yeah, we'll get that. All right.